Welcome to our welcome to our channel Language Clinic. In this channel, we talk about education. Education is entertainment, and education is power. So, if you like any topic on education, and if you are for the first time watching this channel, please subscribe to this channel. Please like and please comment. we will we are going to talk about now from cardiology, and the name of the chapter or today's topic is heart failure with preserved ejection fraction. From this book we are going to talk about almost 13 questions and the answer to these questions. We have here only 13 questions about heart failure with preserved ejection fraction and the answer to the questions. I hope you do enjoy while listening to this video and lecture. Heart failure with preserved ejection fraction. Question number 1. Describe diastolic dysfunction. Diastolic dysfunction, or simply DD, is defined as increased viscoelastic chamber stiffness, impaired ventricular relaxation, or a combination of both. Decline in left ventricular or LV compliance occurs with aging and may be accelerated by conditions such as hypertension, diabetes, and obesity. DD or diastolic dysfunction can occur in the absence or presence of systolic dysfunction and may not necessarily lead to clinical symptoms. However, in some instances, DD or diastolic dysfunction can impede LV filling, increase LV pressures, and reduce LV preload at rest and with exercise, leading to symptoms of dyspnea, orthopnea, and bilateral lower extremity swelling. Now let's talk about question number 2. What is heart failure with preserved ejection fraction, or simply HFpEF? The answer to the question of heart failure with preserved ejection fraction is impaired relaxation can lead to increased LV or left ventricle filling pressures, which can promote heart failure or HF symptoms such as dyspnea and orthopnea. While DD or diastolic dysfunction has historically been the pathophysiological basis for these symptoms, recent investigation has discovered that numerous causal pathways may contribute to heart failure with preserved ejection fraction. Hence, this condition is termed heart failure with preserved ejection fraction, or HFpEF, rather than diastolic heart failure. In contrast to heart failure with reduced ejection fraction, or HFrEF, which is mechanistically linked to pathological LV remodeling, neurohormonal activation, and impairment in systolic function. Regardless of the underlying etiology, no singular pathway is implicated in the development of heart failure with preserved ejection fraction. Rather, multiple mechanisms related to systemic inflammation, disruption in metabolic metabolism, microvascular dysfunction, and reduced LV compliance may all contribute to the development of heart failure with preserved ejection fraction. Furthermore, studies have identified multiple phenogroups of heart failure with preserved ejection fraction with distinct clinical characteristics and prognosis, highlighting the heterogeneity of this entity. The 2013 American College of Cardiology, or ACC, or American Heart Association, or AASA, or Heart Failure Society of America, HFSA, heart failure guidelines define heart failure with preserved ejection fraction as the presence of heart failure symptoms with LVEF, or left ventricular ejection fraction, greater than or equal to 50%. So now let's talk about question number 3. Describe the epidemiology of heart failure with preserved ejection fraction. 5 million individuals in the United States are estimated to have heart failure. Of these, approximately 50% have heart failure with preserved ejection fraction. The prevalence of heart failure with preserved ejection fraction relative to heart failure with reduced ejection fraction is increasing by 1% every year. Accordingly, heart failure with preserved ejection fraction is projected to be the dominant subtype of heart failure in the coming decades. Estimates of heart failure with preserved ejection fraction prevalence range between 1% and 5% in the United States. Heart failure with preserved ejection fraction is projected to cost 70 billion US dollars to the United States healthcare system by 2030. The highest rates of heart failure with preserved ejection fraction are observed in elderly women, though younger patients less than 65 years of old account for 40% per 1,000 persons in black men, 7.8 per 1,000 persons in white women, and 6.3 per 1,000 persons in white men. Lifetime risk of heart failure is higher in men than in women. However, lifetime risk of heart failure with preserved ejection fraction is comparable between men and women, 26% versus 22%. That means men 26% and women is 22%. Furthermore, lifetime risk of heart failure with preserved ejection fraction is higher in non-black than in black individuals, 11.2% in non-black and 7.7% in black individuals. Now, question number 4. Who is at highest risk of heart failure with preserved ejection fraction? The answer is individuals at highest risk of incident heart failure with preserved ejection fraction tend to be older women. Reduction in LV compliance with aging may contribute to excess risk of heart failure with preserved ejection fraction among the elderly. Other risk factors for heart failure with preserved ejection fraction include hypertension, obesity, physical inactivity, coronary artery disease, and atrial fibrillation. Valvular heart disease involving stenosis or insufficiency of the aortic or mitral valve can also lead to diastolic function and subsequent heart failure with preserved ejection fraction. Non-cardiac conditions such as chronic kidney disease, obesity, excess central adiposity, type 2 diabetes, sarcopenia, skeletal myopathy, and frailty increase the risk of developing heart failure with preserved ejection fraction. So that's all about the question who is at highest risk of heart failure with preserved ejection fraction. Now, question number 5. What is the morbidity and mortality of heart failure with preserved ejection fraction? The answer is the relative morbidity and mortality of heart failure with preserved ejection fraction compared to heart failure with reduced ejection fraction is uncertain. Some studies report comparable risks of adverse outcomes in heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, while other studies suggest heart failure with preserved ejection fraction has a better prognosis compared to heart failure with reduced ejection fraction. The in hospital mortality rate for heart failure with preserved ejection fraction ranges from 2.4% to 4.9%. After heart failure hospitalization, the 5-year mortality for heart failure with preserved ejection fraction is roughly 40%. The annual death rate for heart failure with preserved ejection fraction is 8% to 12% in the United States, with 80,000 deaths attributed to heart failure with preserved ejection fraction in 2017. Heart failure with preserved ejection fraction mortality has improved only modestly in the last decade due to a dearth of effective pharmacological therapies. Comorbidity burden is associated with greater risks of adverse events in patients with heart failure with preserved ejection fraction compared to patients with heart failure with reduced ejection fraction. Furthermore, elevated natriuretic peptide renal insufficiency and reduced right ventricular function or RV function are each associated with increased mortality among patients with heart failure with preserved ejection fraction. Question number 6. Describe the pathophysiology of heart failure with preserved ejection fraction. And the answer is a unifying pathophysiological mechanism for the development of heart failure with preserved ejection fraction has not been discovered. Historically, DD or diastolic dysfunction has been the defining cardiac pathophysiological feature of heart failure with preserved ejection fraction. Abnormalities in active LV or left ventricle relaxation and passive LV diastolic stiffness contribute to elevated LV and left atrial or LA diastolic pressures, which can lead to elevated pulmonary capillary wedge pressures, causing heart failure symptoms such as dyspnea on exertion, orthopnea, elevated pulmonary and paroxysmal nocturnal dyspnea. Moreover, stiff myocardium cannot augment LV and diastolic volume and stroke volume via Frank-Starling mechanisms in response to excess LV filling pressures. Thus, heart failure with preserved ejection fraction patients may be asymptomatic at rest, but symptomatic with exercise due to pulmonary venous congestion from elevated pulmonary capillary wedge pressures. Although DD is associated with heart failure with preserved ejection fraction, it is not necessary for the diagnosis of heart failure with preserved ejection fraction. Other pathological mechanisms for heart failure with preserved ejection fraction include chronotropic incompetence, autonomic dysfunction, systemic and pulmonary vascular dysfunction, reduced nitric oxide availability, LA left atrial dysfunction, RV or right ventricle dysfunction, and peripheral impairment. Peripheral factors that contribute to heart failure with preserved ejection fraction pathophysiology are related to abnormalities in skeletal muscle structure and function. Studies evaluating body composition in patients with heart failure with preserved ejection fraction have demonstrated that heart failure with preserved ejection fraction patients have lower lean total body and leg mass compared to healthy individuals. Moreover, individuals with heart failure with preserved ejection fraction tend to have higher intramuscular fat content, lower type 1 muscle fibers, and lower capillary density. These abnormalities reduce efficiency in metabolizing oxygen, reducing exercise tolerance. Consistently, aerobic capacity measured by peak oxygen consumption or peak VO2 is depressed in patients with heart failure with preserved ejection fraction compared to healthy individuals. So that's all about question 6. If you are enjoying listening to this lecture on heart failure with preserved ejection fraction on the chapter on the topic cardiology, please subscribe to the channel, please like and please make some comments on this video. So now let's go to question number 7. What factors can precipitate decompensated heart failure with preserved ejection fraction? Perturbations in comorbid conditions driving heart failure with preserved ejection fraction can lead to acute exacerbations. For example, in patients with heart failure with preserved ejection fraction and hypertension, elevated or uncontrolled blood pressure can decompensate heart failure with preserved ejection fraction due to increased afterload. In patients with paroxysmal atrial fibrillation and heart failure with preserved ejection fraction, conversion to atrial fibrillation results in loss of atrial kick, a significant component of diastolic filling. Moreover, rapid ventricular rates reduce diastolic filling time, which can exacerbate DD or diastolic dysfunction and worsen heart failure with preserved ejection fraction symptoms. Finally, non-adherence to diuretic therapy, high sodium intake, myocardial ischemia, sepsis, and acute renal dysfunction can all precipitate heart failure with preserved ejection fraction. Now, question number 8. How is heart failure with preserved ejection fraction diagnosed? And the answer is heart failure is a clinical diagnosis based primarily on signs and symptoms. However, unlike heart failure with reduced ejection fraction, heart failure with preserved ejection fraction is heterogeneous in its clinical presentation. Comorbidity burden, epidemiology, and pathophysiology. This heterogeneity is reflected by lack of consensus regarding the definition of heart failure with preserved ejection fraction. In a study where investigators diagnosed heart failure with preserved ejection fraction based on preserved ejection fraction and elevated LV filling pressures at rest or with exertion. 91% of individuals met the diagnostic criteria for heart failure with preserved ejection fraction according to the ACC or American College of Cardiology or American Heart Association definition. However, in the same study, only 17% met diagnostic criteria based on the Heart Failure Society of America definition for heart failure with preserved ejection fraction. Currently, there is no conceptual framework for how to account for this heterogeneity in the diagnostic workup for heart failure with preserved ejection fraction. A proposed algorithm suggests a probabilistic approach based on volume status, non-invasive assessment, and stress testing. Signs and symptoms such as dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, elevated jugular venous pressure, bibacillar crackles, and bilateral lower extremity edema all suggest the diagnosis of heart failure. If ejection fraction is greater than 50%, then secondary causes of heart failure with preserved ejection fraction such as pericardial disease, right-sided heart failure, valvular disease, high output heart failure, and primary cardiomyopathy should be ruled out. Once secondary causes of heart failure with preserved ejection fraction are ruled out, a probabilistic assessment of heart failure with preserved ejection fraction risks can be performed based on comorbid conditions and echocardiographic findings such as DD, LV hypertrophy, LV volumes, LA volumes, and functional testing, 6-minute walk test, cardiopulmonary exercise test. Further assessment can be performed using diagnostic scores for heart failure with preserved ejection fraction, such as the Heart Failure Association, HFpEF, or European Society of Cardiology, or ESC, HFA pretest assessment, echocardiography, and natriuretic peptide functional testing, final etiology, or PEFF score, or the HFpEF score. If HFpEF is not likely, other etiologies can be considered. If there is intermediate probability of heart failure with preserved ejection fraction, further workup can be done. Right heart catheterization at rest and with exercise can be performed to assess for increased LV filling pressures either at rest or with exertion. Additionally, assessment of DD with echocardiography tissue Doppler E by E, capital E by small e, with exertion can provide further diagnostic information. A detailed review of this algorithm is shown in figure 23.1. I will show you later in this figure. There is the measurement. Most recently, the 2016 UESC guidelines for the diagnosis of heart failure with preserved ejection fraction include an EF, or ejection fraction, is equal to 50% or more than 50%, elevated natriuretic peptides, presence of DD or structural heart disease, and signs and or symptoms of heart failure. So that's all about the diagnosis of heart failure with preserved ejection fraction. Now question number 9. How is heart failure with preserved ejection fraction worked up after diagnosis? While most heart failure with preserved ejection fraction cases are related to a common set of risk factors and comorbidities, there are specific etiologies that may warrant consideration depending on the clinical context. Non-infiltrative and infiltrative cardiologies that may cardiomyopathies, hypertrophic cardiomyopathies, idiopathic or acquired myocardial fibrosis, muscular dystrophy, toxicity, drugs, radiation, heavy metal, chronic inflammatory cardiomyopathy can all present as heart failure with preserved ejection fraction. When etiologies such as these are being considered, more sophisticated workup may involve cardiac magnetic resonance imaging, or MRI, to detect scar, myocardial edema, microvascular dysfunction, and fibrosis. Technetium pyrophosphate scintigraphy scan, or endomyocardial biopsy to detect cardiac amyloidosis, and genetic testing. Now question number 10. Describe the test used for DD, or diastolic dysfunction. The 2016 American Society of Echocardiography, or ASE, or European Association of Cardiovascular Imaging, or EACVI, guidelines for LVDD involve assessment of myocardial structural disease and estimation of LA volume. 4 echocardiographic parameters are used to assess for DD: biplane LA maximum volume index, ratio of peak mitral E or early diastolic velocity to the average of septal and lateral E velocities. Early diastolic velocity at septal and lateral sides of the mitral annulus E, and peak T or velocity from multiple windows using the highest velocity. If most volumes are within the normal range, then diastolic function is considered normal. However, if most of the echocardiographic parameters are abnormal, then LVDD is diagnosed. Subsequently, LV filling pressures can be estimated using mitral velocities, peak mitral E, capital E velocity, and E by A ratio. Mitral velocities categorize patients into 4 categories: grade 1 DD, characterized by normal LV filling pressure, capital A by capital A ratio is equal to or less than 0.8 with peak capital E velocity more than or less equal or more than 50 centimeter per second. Grade 3 DD E by A ratio is equal to or more than 2. And intermediate diastolic function, if diastolic function velocities and E by A ratio with Valsalva amplitude, peak velocity of atrial reversal signal in pulmonary veins, the presence of L wave velocity more than or equal to 50 centimeter per second in mitral inflow, and comparison of mitral inflow pattern with tricuspid inflow velocities with respect to E by A ratio. The guidelines support a different approach in patients with specific cardiac diseases such as atrial fibrillation, hypertrophic cardiomyopathy, group 1, 3 or 4 pulmonary hypertension, moderate or severe mitral annular calcification, or significant mitral valve disease. Cardiac MRI also can be used to assess diastolic function. Parameters such as LV mass, LH size and function, mitral inflow and pulmonary venous velocity profiles, and myocardial deformation can be derived from cardiac MRI. Diastolic stress testing in select clinical situations can be helpful in the assessment of DD. Right heart catheterization is performed while patients exercise on a variable load ergometer bicycle in the supine position. Intracardiac pressure measurements are captured, including LV systolic pressure, minimal LV pressure, LV and diastolic pressure, and mean LV diastolic pressures. The dP by dt maximum and dP by dt minimum can also be captured, and the time constant of LV relaxation tau can be computed, which can be used to approximate LV relaxation. Although invasive assessment of diastolic function is the gold standard, non-invasive testing is more pragmatic and clinically applicable. Mitral inflow, capital E, and mitral annulus, small e, velocities assessed with Doppler and tissue Doppler echocardiography, respectively, can be used to estimate LV filling pressures. As the transmitral gradient increases, capital E and small e velocities increase proportionally in patients with normal myocardial compliance. In contrast, small e velocity minimally changes in comparison to capital E velocity in patients with abnormal myocardial relaxation. Thus, during exercise, capital E by small e increases in patients with myocardial disease, but does not change in response to exercise in patients with normal myocardium. During diastolic stress testing, Doppler echocardiography is performed during exercise with change in capital E by small e indicating exercise-induced increase in diastolic LV pressures. So that's all about the question. Describe the test used for DD or diastolic dysfunction. Now let's talk about another question, question number 11. And the question is, how do you treat acutely decompensated heart failure with preserved ejection fraction? And the answer is, the acute management of decompensated heart failure with preserved ejection fraction is outlined in the 2013 ACC, American College of Cardiology, American Heart Association, or Heart Failure Society of America heart failure guidelines, and centers around volume management, blood pressure control, and reversal of precipitating factors. If a patient is hospitalized for decompensated heart failure with preserved ejection fraction, volume management requires treatment with intravenous diuretics. Optimal treatment necessitates the use of loop diuretics, which can be augmented with thiazide-like diuretics to achieve sufficient diuresis. The goal of diuresis is to achieve euvolemic status with caution taken to avoid over-diuresis, which may result in hypotension or acute renal injury, particularly in patients with small LV volumes who require less fluid removal while administering diuretic therapy. It is necessary to monitor renal function, creatinine, blood urea nitrogen, electrolytes, sodium, potassium, magnesium, and clinical parameters, symptoms, jugular venous pressure, daily weights, to assess progress and evaluate for potential harm from diuresis. If adequate diuresis cannot be achieved with diuretics, then ultrafiltration can be performed. Blood pressure control is necessary as high afterload directly contributes to elevated LA pressure, LV diastolic pressure, and pulmonary capillary wedge pressure. There is no specific antihypertensive agent that improves outcomes in decompensated heart failure with preserved ejection fraction. The goal should be reduction of blood pressure to less than 130 by 80 mm mercury or mmHg. Finally, identifying precipitating factors is a cornerstone in the management of decompensated heart failure with preserved ejection fraction. If the patient is having ischemia leading to worsening diastolic function, left heart catheterization with subsequent revascularization in addition to volume and blood pressure management can lead to more swift resolution of symptoms. As previously mentioned, atrial fibrillation with rapid ventricular response impairs diastolic filling via lower diastolic filling time and loss of atrial kick. Rate control with beta blockers, non-dehydropyridine calcium conversion, calcium channel, and digoxin can improve diastolic filling time. Rhythm control with antiarrhythmic or with a DD cardioversion can improve diastolic function via conversion to sinus rhythm. Other driving factors such as anemia, infection, and infiltrative cardiomyopathy such as sarcoid or amyloid all require specific therapies beyond volume and blood pressure management. Evaluation and treatment of these entities are warranted in the appropriate clinical context. Now, question number 12, and I have already uttered that we are going to discuss only 13 questions. on heart failure with preserved ejection fraction. And now we are going to talk about question number 12. And if you are enjoying listening to this video, please subscribe to the channel, please make comments, and please press a like on the video. Now let's talk question number 12. How do you treat patients with chronic heart failure with preserved ejection fraction? Once again, I'd like to show you, I am reading from this book, Cardiology Secrets. This book is very handy and very easily understandable. You can easily understand the textbook if you have this book at your bedside. Okay, how do you treat patients with chronic heart failure with preserved ejection fraction? The answer is non-pharmacological therapy such as dietary sodium restriction, 2 to 3 gram per day or daily home weight monitoring, medication compliance, and regular follow-up is recommended in patients with heart failure with preserved ejection fraction. Obesity, diabetes, and hypertension are risk factors for high heart failure with preserved ejection fraction and are associated with greater morbidity and mortality after diagnosis. Accordingly, optimization of these risk factors is important for the prevention and management of heart failure with preserved ejection fraction. More recently, exercise training has been shown to improve physical fitness and quality of life among patients with heart failure with preserved ejection fraction. While pharmacological therapy with beta blockers, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers, or mineralocorticoid antagonist, angiotensin blocker with neprilysin inhibitors has demonstrably been shown to improve outcomes in patients with heart failure with reduced ejection fraction. No single agent has proven efficacious in reducing mortality among patients with heart failure with preserved ejection fraction. I repeat, I do emphasize the line here, the sentence here. No single agent has proven efficacious or effective in reducing mortality or the death rate among patients with heart failure with preserved ejection fraction. The 2017 ACC, American College of Cardiology, or American Heart Association, or Heart Failure Society of America heart failure guidelines recommend the use of angiotensin receptor blockers class 2B, level of evidence B, and treatment with mineralocorticoid receptor agonist class 2B, level of evidence BR, to reduce the risk of heart failure hospitalization among patients with heart failure with preserved ejection fraction. These recommendations are based on the mortality and morbidity reduction with candesartan in patients with chronic heart failure and left ventricular systolic dysfunction CSARM preserved, and spironolactone for heart failure with preserved ejection fraction TOPCAT trials, which demonstrated reduced heart failure hospitalization rates in patients with heart failure with preserved ejection fraction treated with candesartan and spironolactone, respectively. The updated 2017 ACC or ASA or HFSA heart failure guidelines do not recommend treating chronic heart failure with preserved ejection fraction with nitrates or phosphodiesterase inhibitors. Recently, the angiotensin neprilysin inhibitor in heart failure with preserved ejection fraction Paragon heart failure trial did not show improvement in outcomes among patients with heart failure with preserved ejection fraction treated with sacubitril valsartan versus valsartan alone. However, this study suggested potential benefit in female participants or participants with and LVEF below 57%. Society guidelines have not yet incorporated these data into recommendations. Finally, among patients with heart failure with preserved ejection fraction who also have comorbid conditions such as hypertension, coronary artery disease, diabetes, and atrial fibrillation, appropriate pharmacological therapies ought to be administered to optimize these conditions in accordance with the updated 2017 ACC or ASA or HFSA guideline recommendations. Now we are going to talk about the last question on the chapter heart failure with preserved ejection fraction. Once again, I'd like to show you. I am reading from this book, Cardiology Secrets. This book is very handy, and this book is written in very easily understandable English. And if you like to be interested on cardiology, you can buy this book and you can read this book. I do think this book helps you a lot in your understanding of cardiology in easy English. Okay, now this is the last question on this chapter. And if you are watching for the first time, this is a channel of education. Please, if you like, you can subscribe to this channel. Question 13 and the last question. What are the class 1 recommendations for the treatment of heart failure with preserved ejection fraction? The answer is, according to the updated 2017 ACC, American College of Cardiology, or American Heart Association, or Heart Failure Society of America heart failure guidelines, the class 1 recommendations for heart failure with preserved ejection fractions include systolic and diastolic blood pressure should be controlled. Systolic blood pressure should be controlled and diastolic blood pressure should be controlled in patients with heart failure with preserved ejection fraction in accordance with published clinical practice guidelines to prevent morbidity. Number 2, diuretics should be used for relief of symptoms due to volume overload in patients with heart failure with preserved ejection fraction. So that's all about the chapter heart failure with preserved ejection fraction. Once again, I'd like to show you this book. This book is a handy book, and this book is written using very lucid English, and I think any layman can understand this book. If you enjoy listening to this lecture on heart or cardiology or heart failure with preserved ejection fraction, you can subscribe to this channel. You can be a member of this channel. This is a channel of entertainment. This is a channel of education. Education is entertainment. If you gain more education, you become more entertained, because knowledge entertains us. Knowledge makes us happy. Knowledge makes us have fun. So have some fun. Enjoy your life. Enjoy your life with a good heart. Thank you. Bye-bye for watching patiently.